every Wednesday evening with a new and hot topic in his sub-specialty of orthopedics. Under the chairmanship of Dr. Mohanty and Secretary Dr. ASHISH PHADNIS, Dr. SWAPNIL, KENY, and myself, Dr. DEEPAK GAUTAM. Dr. Mohanty is the professor and unit head in the Department of Orthopaedics at SGS Medical College and KEM Hospital, Mumbai. He is also an honorary consultant at Jasbrook, Nanavati, and Susrisha Hospital. He is the past president of Indian Orthoplasty Association and Bombay Orthopedic Society. He is a great academician and researcher. He is the education chair of Indian Society of Hip and Knee Surgeons, reviewer of famous journals BJJ, SICOT, and our own Indian Journal of Orthopedics. Today is the day of controversies in degenerative disorders, and we have specifically dedicated today's webinar to our military doctors. We have our eminent speaker, Lieutenant Colonel Dr. Saurabh Sharma from the FMC Pune, along with moderators, Lieutenant Colonel Dr. Sumit Bhandari and Lieutenant Colonel Dr. Rohit Vikas. I would now like to call upon Professor Mohanty to introduce our speaker and the moderators and proceed with the session. Dr. Mohanty, sir, all to you now.
So, good evening, dear friends. Greetings from Mumbai and welcome to the 11th episode of Controversies and Consensus in Orthopedics. And today, we are privileged to have three eminent specialist orthopedic surgeons from Army Medical Corps. So it's a really pleasure and honor to introduce them in this forum. Let me first introduce our moderators for today. Dr. Lieutenant Colonel Sumit Bhandari is MBBS DNB in Orthopedics and is at present Associate Professor at Armed Forces Medical College, Pune. His affiliated hospitals are Military Hospital in Jalandhar, Base Hospital, Delhi, Military Hospital in Kharki, Pune, Command Hospital, Pune, FMC Complex. His specialization is trained in pediatric surgery, orthopedic surgery at Sancheti Hospital. And his special interest is pediatric orthopedics, which, especially deformity correction and dysplastic hip. I welcome, Dr. Lieutenant Colonel Sumit Bhandari to the 11th episode of Controversies and Consensus. Thank you, Dr. Bhandari, joining today.
Thank you very much, sir. Good evening.
Good evening to you. Again, we have our moderator, Dr. Lieutenant Colonel Rohit Vikas. He is MBBS MS Orthopedics from AFMC itself and at present Associate Professor of AFMC Pune. And his affiliated hospitals are Military Hospital Jalandhar, Command Hospital Mumbai, Military Hospital Kharki, Pune, Military Hospital Lucknow, Command Hospital Pune, FMC Complex, and Army Hospital RNR, New Delhi. His specialization that he is trained in joint replacement surgery at Army Hospital RNR, Delhi, and AIMS under Professor Rajesh Malhotra. His special interest is complex trauma, pelvic surgeries, and revision knee and hip surgeries. Welcome, Dr. Rohit Vikas, today to this episode of Controversy and Consensus, and we thank you for joining today. And our eminent speaker today is Dr. Lieutenant Colonel Saurabh Sharma, and who is MBBS MS Orthopedics from AFMC and Associate Professor at AFMC Pune as well. And his affiliated hospitals are Military Hospital Jalandhar, Command Hospital Kolkata, Military Hospital Kharki, Pune, Army Hospital RNR, New Delhi, Military Hospital Sikandrabad, Command Hospital Pune, FMC Complex. His specialization is his trained in joint replacement surgery at Army Hospital RNR, Delhi, and England as well. And his special interest is primary complex hip surgeries and revision knee and hip surgeries. Welcome, Dr. Saurabh Sharma, today to this episode of Controversial Consensus. And without much ado, I would like to invite you to deliver your lecture on the controversies about Visco supplementation in osteoarthritis knee. Thank you for joining today and welcome.
Thank you, sir.
Over to you, Dr. Saurabh Sharma, please.
Sure.
Are you able to see the screen?
Yes,
Yeah.
I can see the screen.
Whenever you tell, I'll change the slide, okay?
Yes, thank you for this. Good evening, everyone. First of all, my apologies for a slight delay due to the fault in my screen sharing. With that being said, greetings from Pune and Army, and especially from my present hospital, Military Hospital, Kharki, FMC Pune complex. Next slide, please. So, as the topic of today is Visco supplementation in osteoarthritis of the knee. So, before we proceed, we should talk something about the disease per se, that is the osteoarthritis of the knee. So, it's the most common form of arthritis in an elderly population, or more to say, in not so elderly too. As per the American data, it affects almost 22.7% of the adult population, and knee is the most commonly affected joint in their subset, up to 41%. I'll not be surprised if we had the correct data of the Indian subset. This would be nearing around 60%, because in our subset, because our lifestyle, majority of the joints affected with arthritis are primarily the knees and not so other joints. And with the likely scenario of the Indian subset of population, which will have more number of middle-aged people between 40 and 50, the disease burden is likely to increase over the next 10 years. So what happens in a knee osteoarthritis is basically because of the mechanical stress. There's a cartilage degeneration due to various modalities like trauma or the degeneration of the matrix of the cartilage tissue, which leads to secretion of inflammatory mediators like interleukins, TNFs, nitric oxides, and which starts a cascade of events which ultimately leads to cartilage destruction and bone remodeling, and which is known as osteoarthritis and a painful knee joint. So when mechanical transmission is transmitted to the cartilage in a normal individual, there are various factors and enzymes which are secreted in the matrix by the cartilage cells. In a normal tissue or in a healthy cartilage, there is a balance between the anabolic and the catabolic response to the mechanical stress. So when this balance gets off, then there is a hyperactivity of catabolic response, leads to degeneration of cartilage, and this progressively keep worsening with repetitive loading of the joint. So this slide, as we can see, the most widely used classification, WHO accepted Kellgren-Lawrence grading scale for osteoarthritis. We know what to do in the, sorry, can we do the next slide, please? Sorry. Next slide, please. I went on with my presentation. I just forgot to tell you, please do the next slide, sir. Yeah, so coming on to this slide, as we can see, we know the treatment for the X-ray picture on the left-hand side and also the X-ray picture on the right-hand side. It's the intervening two grades, that is grade 2 and 3, which there is a dilemma what to do and when to do. More so when the patients are not too receptive and not too keen on any surgical intervention. So all the treatment modalities which are non-surgical and which are having little bit of controversies are aimed at treating these kind of patients, the grade 2s and grade 3s, and sometimes grade 1 in high demand individuals. And the number of such patients likely to increase over the next 10 years. Next slide, please. So before we go on to the visco supplementation, a word or two about synovial fluid. The viscoelastic property of a synovial fluids are critical to its function of lubrication of and shock absorption of joint in the human body. The hyaluronic acid, which is a naturally occurring and integral part of a healthy cartilage and synovial fluid, is secreted by the synovium, and it acts as a viscoelastic material which reduces the stress during mechanical load transfer in the joint. It is composed of repeating disaccharide units formed by N-acetyl D-glucosamine and D-glucuronic acid. Next slide, please. So what happens in a normal joint and what happens in an abnormal joint? There is always a pro-inflammatory mediators and anti-inflammatory mediators. The pro-inflammatory mediators are secreted as a result of mechanical stress, and the anti-inflammatory mediators are partly uh, uh, partly due to the presence of this hyaluronic acid in the synovial fluid, which tend to act as a stress reliever, and this removes some of the pro-inflammatory mediators and also reduces the shear stress in the joint by acting as a viscoelastic material. Next slide, sir. As various studies have indicated, the hyaluronic acid, which is present in the normal synovial fluid, has many chondroprotective biochemical function. Wang et al. In 2006 showed that hyaluronic acid downregulated the expression of pro-inflammatory cytokines through its interaction with the synoviocytes in the joint space. Next slide, please. Yasuda et al. Also showed that hyaluronic acid suppresses macrophage production of prostaglandin E2 by downregulation of NF-kappa B gene. Next slide, please. Sasaki et al. In 2004 showed that expression and production of matrix metalloproteinases and proteases, which are involved in the degradation of matrix proteins, which will eventually contribute to maintaining the integrity of the joint, is decreased in the presence of hyaluronic acid. So it is very important to reduce these enzymes in the matrix of the cartilage. Next slide, please. So change in the synovial fluid basically happens in osteoarthritis. The quality and the quantity of hyaluronic acid, where it changes from a viscoelastic to a lesser viscoelastic material, that is due to depolymerization of the native hyaluronic acid molecules. So various treatment modalities of viscosupplementations are basically supposed to work on the principle of replacing this native hyaluronic acid, hence delaying the disease progression. Next slide, please. So how do you treat the knee pain due to osteoarthritis in subset? Next slide, please. So treatment options are various, and we are discussing one of those, that is injectables, that is viscosupplementation. Next slide, please. So whenever we choose a new treatment modality or advise any treatment modality for a patient, it should be based on the status of the disease, that is classification, what stage is the patient, then evidence supporting the treatment offered, and patient acceptance of treatment and patient profile. So we will be discussing the remaining thing based on primarily on these three factors. Next slide, please. Viscosupplementation in any arthritis is a major treatment modality which is being widely accepted world over by orthopedic surgeons, some, and promoted a lot by rheumatologists world over. As far as the evidence is concerned, we have evidence to support either way, for and against. So what to choose, which path to take, is there any harm or is there any benefit? We'll dwell on it for some more time with some expert feedback from our expert panelists. Next slide, please. Before we proceed, let me tell you the viscosupplementation market is coming up in a big way. It's expected to touch $7 billion market by 2027. So there will be a lot of market push. So before we choose it, we need to be fully aware whether it is definitely going to make a difference to our patients. Next slide, please. That all being said in the beginning, we should try and find out if the use is supported by science and proceed from there. Next slide, please. Degenerative disease of the knee joint will lead to degraded quality of the synovial fluid. Fluid will lose its viscoelasticity, hence lead to added stress on the chondrocyte. The concept behind viscosupplementation is changing this fluid to more natural type of synovial fluid, hence delay or halt the progression of disease and provide relief of symptoms. Next slide, please. There are various types of viscosupplements which are available: low molecular weight, high molecular weight, single dose, multiple dose. When it comes to classification, there are basically two: a native type or a highly cross-linked type, a low molecular weight type versus a high molecular weight type of hyaluronic acid. Next slide, please. The high molecular weight are like Highland GF20, which comes in two formation, a single dose one or a 3 doses one, which is marketed as Synvis or Synvis 1. It is said that it mimics a naturally occurring hyaluronic acid, and it's closer to the molecular weight of a naturally occurring hyaluronic acid in the synovial fluid. However, that being said, the half-life of this Highland GF in a joint is 26.1 hours. That means within a day, half of it is being taken away by the lymphatics. Next slide, please. Then is sodium hyaluronate. It's a salt form of hyaluronic acid and is a glycosaminoglycan formed from long-chain disaccharide sodium glucuronate and acetyl glucosamine units. This can be given as weekly injection for 3 to 5 weeks. It is a naturally occurring substance found within connective tissues. It has also been shown to provide benefits and also has been linked to anti-inflammatory properties. Then as Durolon is a single injection product using a cross-linked sodium hyaluronate agent. It is derived from biofermentation with a half-life of approximately 4 weeks. Then there is a hyaluron. It's a high molecular weight extracellular matrix polysaccharide and a hyaluronic acid derivative. So various products which are having this hyaluron are Orthovis, Homovis, or Monovis. These are extracted and purified with bacterial fermentation. Hyaluron is a polymer used as a viscose supplement that is supposedly supposed to modulate the expression of inflammatory gene by cell surface receptors such as CD4, RAM, and Toll-like receptors, and regulate the downstream signaling, hence decreasing the inflammation or the pro-inflammatory markers inside the knee joint. Aside from the potential role in inflammation pathway, this also acts as a viscoelastic shock absorber by virtue of its size in presence of extracellular matrix, and because of its rheological properties which are closer to the natural synovial fluid. Next slide, please. Sorry, next slide. Yeah, next one, please. The pain relieving effect reported in patients who receive visco supplementation is directly related to the viscosity of the product used for intra-articular injection. It has been postulated that cross-linking of formulation is intended to allow for longer lasting efficacy by increasing the resistance to degradation within the knee joint. Next slide, please. With all this being said about the about the product and what does it do, it is not without some serious adverse events, but to our fortune, those serious adverse events are not very frequent. The commonest being pain at the site of injection, local skin reaction, pseudoseptic reaction, septic arthritis, and local joint pain and swelling, which may last more than 4 to 6 weeks. Next slide, please. Various authors have had these, have projected that there is a definite incidence of some serious pseudoseptic reactions with the use of Highland GF20 compared to other hyaluronic acid preparations. Goldberg and colleagues suggested this in their paper, which was published in Clinical Orthopaedic Related Research way back in 2004. Next slide, please. Ishikawa in 2014 also suggested that Highland GF20 is less biocompatible and higher immunogenicity compared to the different cross-linked hyaluronic acid formulations with correspondingly high rate of pseudoseptic reactions. Next slide, please. Coming on to the evidence and guidelines regarding the use of visco supplements in our day-to-day practice. Starting with as back as 2006, there was a Cochrane review which included 76 randomized controlled trial evaluating visco supplementation with the diagnosis of knee osteoarthritis in at least one branch. They supported the efficacy of visco supplementation against placebo. But when you go deeply in this Cochrane review, we find that most of these studies had rheumatologists as the primary care physician to using this visco supplementation in their practice. The authors reported beneficial effects on pain, physical function, and global assessment, the strongest finding between 5 to 13 weeks in this review. However, despite this conclusion, substantive conclusion, which gave a definitive support to the use of visco supplementation, it is 2023, and currently available guidelines and meta-analysis still have conflicting recommendations. Next slide, please. The guideline published by the American Academy of Orthopaedic Surgeons in 2013 stated that hyaluronic acid for patients with symptomatic osteoarthritis of the knee cannot be recommended, noting that most of the literature surrounding visco supplementation has a significant degree of bias, publication bias. And this was published, this guidelines were published in JBJS American 2016. Next slide, please. In 2014, Osteoarthritis Research Society International Guideline offered an uncertain recommendation for intra-articular use of visco supplementation in knee osteoarthritis. Next slide, please. However, in year 2019, the same society upgraded their recommendation to level 2. That means out of the surgeons involved in putting on these guidelines, 60 to 74% of them were having the visco supplementation. Next slide, please. In 2012, Vergés et al. Concluded that through a comprehensive systematic review and meta-analysis, that visco supplementation is associated with clinically irrelevant benefit and an increased risk of adverse events. This was published in Annals of Internal Medicine in 2012. Next slide, please. 2015, there's again a paper, basically in rheumatology journals. Richard and colleagues concluded through an updated meta-analysis of trials with a low risk of bias that HA supplementation provided a moderate but a real benefit for patients with knee osteoarthritis. Then next slide, please. Coming with the evidence from our own country, from our own convener, Professor MOHANTY. Visco supplementation for management of... Next slide, please. I found this. So next slide, please. So I found these recommendations to be totally relevant in today's practice. So these say that those with symptomatic grade 1 and 2 knee osteoarthritis would be considered ideal patient for these kind of treatment. In patients with grade 3 who are not willing for mechanical realignment surgery, there's an alternative option with not as beneficial as in grade 1 and 2. In elderly patients, this can be a time-buying pain relief option to avoid the side effects of NSAIDs, and so on. Patients who are unwilling to undergo or wish to defer surgery, this can be tried if there is no other alternative option at hand. Next slide, please. In a critical literature review analysis by Nahu et al., the intra-articular hyaluronic acid was found to provide a moderate symptomatic benefit to knee osteoarthritis patients without safety concerns. This was again published in rheumatology journals. So, coming to the next slide, please. The latest guidelines of American Academy of Orthopaedic Surgeons published published on 31 of August 2021. They don't recommend for routine use in treatment of symptomatic arthritis. Next slide, please. Next slide, please. So after having discussed the evidence and gone through the literature over the last few days now, this literature is filled with bias, and there's some totally in favor, and it creates a lot of confusion amongst the newer generation who are new to the visco supplementation. Most of them are, they think that it is a magic drug and give it left, right, and center to everybody. So when come to its rational use, we should decide use or not to use. If to use, which one to use? High molecular weight, low molecular weight, and based on that, how many doses, and whatever it should be the frequency of repeat dosing. Next slide, please. Then there are special situations like elite athletes, most of our army soldiers, middle-aged active individuals who want to pursue sports activity despite some amount of arthritis setting in, and sedentary elderly with poor general physical condition who just want symptomatic relief and unfit or unwilling for a major surgical procedures. Next slide, please. So, based on this, there are some recommending guiding factor which I can conclude. That is, number one is the status of articular cartilage of the joint. That is grade of osteoarthritis. As I discussed initially, grade 1, there is not much doubt. Grade 2 and 3, that is one, there is a gray area, which treatment modality to choose. So it can be considered wisely or with patient discussion and discussing that the treatment is likely to benefit. However, there are rare but potential side effects of the usage of these visco supplements. Then affection of the patellofemoral joint. When we do a clinical examination of the patient and do a radiological confirmation of the disease primarily affects the patellofemoral joint. There's a definite evidence that visco supplementation is not effective when the primarily cause of the knee pain is the patellofemoral joint. Then status of synovial tissue. If the tissue is associated with a lot of inflammation, then as per the logic behind the science of visco supplementation, inflammation is not, the acute inflammation of synovial tissue is not tackled by the visco supplementation. It is more to do with the low-grade inflammation which happen with the repeated mechanical stress. So there is a panels formation which is seen to happen in a chronic case of osteoarthritis. This is not recommended. Then comes patient profile, and if the patient demands, we have to comply with the demands after discussing the pros and cons of the treatment modality. Next slide, please. That's all I have to say on this topic. And coming on to the discussion, that I would request our panelists to please go ahead and shoot.
Should I stop sharing?
Yes, sir. I'm done with the presentation.
So, Colonel Saurabh, it was a nicely reviewed and summarized topic from your side. So, there will be some questions from the audience, and I have few of mine too. And it's basically to just know the current your practice of whether you use hyaluronic acid or no, whether it's totally yes or totally no.
I'm a very abstract person. So I had 3 complications, major pseudoseptic reaction, which I had to take to theater and wash. Ever since then, I have stopped using hyaluronic acid in my practice now.
No, though.
I know visco supplementations.
I'm aware that we also have faced the problem of having local mild reaction to the injection site, and which is generally managed with conservative treatment and some painkillers, NSAIDs, and ice therapy. But this pseudoseptic arthritis, which you had the experience. So you had experience within your current setup or previously?
I have experience within my previous 2 setups. When I was in Command Hospital, Calcutta, very senior VIP came to me that he wanted some visco supplementation in the knee. It was in 2014. So I accepted his request, and this guy landed up with severe knee inflammation, which lasted for almost 6 weeks. Then the other guy when I was in Sikandrabad in 2018. Another officer who came demanding visco supplementation. I was not in favor. He also landed with a severe reaction, and he eventually had to take to theater, wash him, and then it took almost 3 months for him to recover out of it.
Because in a clinical experience of having 3 such cases which required wash is actually alarming. And can you recall that whether it was a specific brand of the visco supplementation? Because we know that local reaction are more with that avian source.
It was with Sinvis 1 because that was within our DGRC. So we were getting DGRC Sinvis 1 in all our hospitals, and it was with Sinvis 1 Highland GF20.
Yeah, the Sinvis 1 I think is a avian derived
yes,
product.
Yes, it's the same one. Yes.
So generally, this sort of septic arthritis or like picture I have not faced. Generally, those are the mild local reaction which occurs, which are easily managed with conservative therapy. And in fact, in my practice, what we do is that before injecting only, we tell the patient that there will be some slight local reaction, which they should not be aware of. They should reduce the activity, apply ice, and take paracetamol or NSAIDs for a few days after the application. And if the local reaction or local pain doesn't settle down within a week and it is increasing, then do come and have a review with the clinician.
Fully agree, sir. But after having faced this actual burnt off pseudoseptic, I am very chary about using it.
So whether you will consider that again.
Do you give antihistaminics or any? Do you give any antihistaminics or any anti-allergy treatment for this kind of reactions?
No, sir. I have not given any antihistaminics. We give NSAIDs, but not antihistaminics. We not.
Also, I recall that there are proponents who use steroid with the hyaluronic acid injections mixed with them, and their basic idea is to reduce this local site injection site reaction to that. So, what is your view upon this, or view of any of the panelists over here, of using both concurrent hyaluronic acid mixed with steroid, like a cocktail?
I have no experience of mixing steroids with hyaluronic acid, personal experience, but I have few patients known who have got steroid along with hyaluronic acid, and 2 of them in my family, and they're doing very well. So
why I'm saying that because I don't, we don't in the army have that combination, but I think in civil setup, a product is there which has both pre-mixed steroid and hyaluronic acid injections. Can any of the civil counterparts confirm or refute this, whether they have a combined injections?
No, we never give steroid injection. At least I never give steroid injection. I've stopped giving intra-articular steroids for last 15 years. Though I give steroid injections to other conditions like, tennis elbow or plantar fasciitis, all these things. But intra-articular steroid injection I have stopped giving because of its obvious side effects, and it is one of the most important cause of post-replacement infection also. That is why I don't inject steroids. Sinvis also, all this visco supplementation, rarely I give. In my practice, at least I treat these patients initially with nutraceuticals. I don't know. I'm very happy with this glucosamine chondroitin products. Whether it acts like a placebo or not, though it is not recommended by American Academy of Orthopaedic Surgeons, but still I give it for 3 months and just see. And I see almost 60-70% of patients, they get improved with their symptoms. At least they provide symptomatic relief. And if it doesn't provide any relief, then the next step is, go for this visco supplementation. And that too in grade 1, grade 2 only.
Quite correct, sir. And my practice is also the same, I think. I never wanted or had that scientific reason behind using of this nutraceuticals. But when it was available with us in the army and we were giving free of cost to the patients, and those patients who doesn't require surgery, but they wanted some sort of pain relief. So I started giving them these rosehip extracts and curcumin extracts. And to an extent of my surprise, that many of the patients do report less use of their painkillers and better in their pain without any having to take any other medications. But of course, I don't have a logic behind it. Why? How does it work? Whether an extract of turmeric or the rosehip do pain relief at a inflammatory level or some other mechanism. But yes, my clinical experience has been that if we offer them for those patients actually who don't require any replacement, so they do come back that saying that these are working for them. And in my opinion, that the process of mixing steroid with hyaluronic acid injection, my idea is that
Okay.
I do I do give hyaluronic acid injections to some subset of patients who are quite young, who don't have a bone-to-bone arthritis. And in any patient who comes to me asking for a steroid for an injection of visco supplementation, and on X-ray, if he has a bone-to-bone arthritis, I don't prefer or recommend giving them these injections, because these are the patients whom I know that the joint replacement is going to work for them, and I don't want to complicate my future surgeries by giving the injection. So with this, another question comes up. Suppose we have given or someone has received an intra-articular injection of any sort, maybe steroid or hyaluronic acid, and we find that it's not affecting them significantly and they require a knee replacement. How long should we wait before performing a knee replacement to them after the injection?
So ideally, you should wait at least 3 to 6 months before we offer any surgical treatment. That's our protocol in our hospital. It was here in MH Khidki, and we followed in Army Hospital. And that was generally being followed when I was being trained in UK. They don't used to do any replacement if they had an injection in the past 6 months.
And this thing, Saurabh, do you recommend mixing lignocaine with intra-articular injections?
With steroids, yes, people do mix it, and I also used to mix it when I used to give steroids. But with hyaluron, no. In this, no.
Okay, because see, there are some people who are mixing this thing even with hyaluron. Mixing of lignocaine with hyaluron, basically a low dose of hyaluron, like not 1% lignocaine, 0.5% lignocaine, just a ml or so. So is it effective or is it recommended to do like that?
As per the recommendation from the company or the product thing is concerned, they don't recommend mixing anything. It comes with a pre-packed needle with a syringe, not supposed to inject it directly into the joint.
So in my practice, what I do is when I give injection of steroids to inflammatory arthritic conditions, I do dilute it by using a plain lignocaine. My idea is that lignocaine should be plain, that should be without any preservative, because those preservatives may cause some local reaction. And generally what happens when I inject the steroid with the intra-articular injections, so immediately the patient says that they have some relief of pain. So I convince the patient that the injection has gone into the correct compartment. So that's why you are having this pain relief. And the steroid will work. It will take its effect in another week or so to reduce the inflammation and pain.
And
so
the other thing is that mixing corticosteroids with intra-articular hyaluron. So basically, the recommendations as such, this American Academy of Orthopedic Surgeons says that visco supplementation should not be given. But the earlier recommendations of American, the same AOS has said that yes, you can mix corticosteroids with this visco supplementation, but that's just supposedly if you're giving 3 injections, in the first injection you can mix that one, but there are conditions laid out for that. That is basically should be given for those cases who have acute inflammation at that time or severe pain at that time, because corticosteroids may help in reducing that inflammation and reducing that pain. So that's why at that time recommendation earlier it was there to mix it with the visco supplementation actually.
So, sir, in my practice, what I do is a good thing that juniors can also learn. I differentiate the arthritic knee into whether it's a hot knee or a cold knee, or a wet knee or a dry knee. It means that look, all these osteoarthritis are having exacerbation of acute pain and inflammation. So in acute pain and inflammation, I generally tend to not use any of the injections of visco supplementation. I because suppose the patient is coming to me with sudden increase of their activity, or suppose he has gone in a wedding or too much of shopping and he comes back, or after a uh, going to some hilly area and he has come back with exacerbation. I generally advise them to take rest, apply some ice, take painkillers, let the knee become quiet. And if I have to inject any of these intraarticular hyaluronic acid, I tend to wait till the knee becomes a bit more less inflamed and quiet. Now, those knees in which there is effusion, I don't think that the viscosupplementation will or should work. In those cases, steroids will be a better option. But yes, not in patients who actually require a joint replacement uh, for their arthritic conditions.
But
As such,
but
for this thing, as
just
such,
1 second before Dr. Sumit's question. In case when there is a effusion, do you aspirate that knee and then inject the visco supplementation? Because the risk of dilution of that visco supplementation may lead to that it may be ineffective.
As I said, that this effusion is basically a marker that there has been some exacerbation because of overuse activity, and my management remains that I convince the patient that don't get it aspirated anywhere else or from me also, unless it is too effusion like a hemarthrosis, painful knee hemarthrosis. So aspiration of knee, it may be a requirement for diagnostic purpose to know whether it's having a rheumatoid element or not. Uh, Otherwise, I don't generally tend to aspirate any effusions of the knee. And aspirating and then re-injecting like a viscosupplementation has been in my practice.
actually, sir, the thing is, the recommendation is that if you have an acute knee or there's an effusion inside the knee, in those cases, if you have to, generally this visco supplementation doesn't work. There are two reasons for that. One is basically dilution because of the lots of fluid inside. And more than dilution, it's basically the cytokines which are present inside that because of inflammation that can lead to faster degradation of the hyaluron what you have given already. So that's why it's generally not recommended for this thing if in an acute knee that or in a swollen knee that this thing visco supplementation should be given. But yes, there is a recommendation also like in elderly, supposedly like 75, more than 75 in those cases with grade 3 osteoarthritis with acute inflammation. In those cases, because of pain and all those things, the inflammation has increased. So in those cases, it's recommended that you mix that visco supplementation with a little bit of steroid because that will reduce the inflammation also, and that can this thing reduce the swelling also.
So I have another question for Colonel Saurabh and rest of the things regarding their practice. Generally, what we see that patient is having a medial component arthritis who may be fit for unicondylar knee replacement, but he also has been given multiple 2-3 injections of some visco supplementation or steroid before coming to a joint replacement surgeon. So is there any change in our plan? Suppose a patient has received multiple injections, and then you know that with X-ray that he is a candidate for unicondylar knee replacement. So whether a multiple previously knee injections changes our choice of unicondylar knee replacement or to a total knee replacement in a medial compartment osteoarthritis. Do you get my question, Saurabh?
I think generally it doesn't. The only thing is it should be 6 months past the last injection. That's in the recommendation. And decision whether a uni or a total has to be based on patient symptoms, patient X-rays, and cartilage damage.
Why? Because I'm saying this now, because when you open a knee with a multiple injection, then the synovium itself is quite granular. So generally enough, while performing a TKR, we remove all the synovium in these cases.
So that we will come to know when we open the knee. If there is a lot of synovial inflammation, then UCK will invariably be shifted to a total knee. But a pre-op decision about this thing, uni or a total, cannot be made based on just how many injections he or she has had. That can be seeing the per-op inflammatory picture. and the synovium seems to be hypertrophied, a lot of infiltration as we see in rheumatoid or close to rheumatoid, then we can change the plan. Otherwise, pre-op is very difficult to call a shot, uni or total.
So I will like to extend this question to our civil counterparts regarding their options. Whether you will go ahead with a uni knee replacement or you will prefer to do a total knee replacement if you find that the patient is having a multiple injections previously. Whether it changes your treatment plan for a medial compartment osteoarthritis.
So, I mean, I don't do too many unis, but I don't think my decision to do a uni or a total will based on the previous injections. But having said that, my volume of uni compartmental itself is very low, and I have a very high threshold of recommending some. So usually, if patient is ideal candidate for a uni, I probably will refer him to our senior colleagues who do those large numbers. But in their practice, also, I've seen that I don't think they base their decision on whether it's a previously injected joint. But yes, I mean, if I get your point that if it's very inflamed and sort of you are expecting inflammatory sort of component in that mechanical OA, then probably they will also go for a total knee replacement rather than a uni.
Yeah, so in my practice, what we do that if the patient is having some history of injection and is a candidate for uni, I pre-warn the patient that I have to open the joint and see if the synovium is quite inflamed. Then I have to proceed with a total knee because I have to do the synovectomy and then proceed with a total knee, and then uni will be a not my preferred in those cases. So decision remains intra-op in these cases.
Right. So can I?
So anyone?
Is there any literature to support that? Actually, this is something which I am learning.
What happens that we our practice has been that in inflammatory arthritis, as such, uni is not recommended because it's a synovial disease, it's not a compartment disease. So anything which replicates a synovial disease, like if you have
rheumatoids, you don't do.
Yeah. Exactly, sir. Because in those cases,
in rheumatoids, you don't prefer to do uni. Yeah.
Because the failure of uni is not the unique procedure itself, but persistence of symptoms. So if you leave behind an inflamed synovium, even if you do a good uni, the patient, because of the synovial pain, he may not be having, and then he will complain that uni is not working for them, and unnecessarily he will get a. So from our civil counterparts, I would like to know that presently in civil markets, because in army what we are looking is we have used Durolin, which is now not available in India. We have Synvix and we have another brand from Mundi Pharma, Monovix. So what is presently available in the market in civil? What do you prefer?
I think a
Out of these,
lot of Indian generic companies also have come up with this Visco supplementation. The place where I practice, I think Synvisc still is very popular. As you know, Durolin caught up. I think it was marketed by Dr. Reddy's, if I'm not mistaken.
Yes.
the orange color one.
Yeah. So I'm not sure if it is available, but yes, Synvisc is there, Monovisc is there, and Alchem also I think used to come with something. But we stock Synvisc.
I remember that once the Reliance had come at Bombay, and they had given us a sample and we used it. And the patient has had that was my first.
Audible.
Dr. Rohit, you are muted by accidentally, I think so. Now you're okay. Yes, now it's okay.
So I was just saying that while I was in Bombay, then from the Reliance we got one of their products, and I used in one patient, and unfortunately the patient had a local reaction, which was the severity of which was the first time which I have experienced. Although it reduced with conservative therapy, but it was a quite threatening for me to use it again.
Sorry, your voice is quite muffled. I think your earphones have, or the mic has stopped probably. And now you're using the laptop mic, probably. That could be one of the reasons.
I'm audible right now?
You're audible, but it's quite muffled. Earlier on, it was much better. So, Dr. Saurabh, can I ask a question
Yes.
based? Yeah, in your presentation, there was a very good paper from India you showed, which was authored by Dr. Mohanty sir, Dr. Sachin Tapaswi, and most of the authors in that paper looked like they were arthroscopy surgeons.
Yes.
There's one arthroplasty and a knee preservation. So did they mention that they would also inject Synvis after a arthroscopic washout or something like that? Was there a role for those?
No. As far the evidence is concerned, there is no role of visco supplementation post surgeries, a cartilage preservation or arthroscopic surgeries or a meniscectomies. In their paper, I didn't specifically look for, but what I went through it, I didn't find a mention for post surgery.
And yes, sir.
Can I just add to it? Yeah, in arthroscopic surgery, especially after doing all this ACL reconstruction, etc., if there are some chondral damage, cartilage damage, then they were of the opinion, because it was a consensus meeting, we held the meeting for a couple of times before we published this paper. So they were of the opinion, the sports medicine people, that they inject Synvis after doing the reconstruction if suppose there is a chondral injury, to to supplement that by single dose.
I also recall that some of the arthroscopic surgeons, after performing the scopic surgery, the same sitting they used to inject in those cases in which they have done some cartilage microfracture or the similar procedures. They used to inject the visco supplementation, the same sitting.
They are very muffled, so you can't hear clearly.
But the thing is that there is one study also which was published, I think in 2016 or so, which said that after all these procedures like meniscectomy or this thing for chondromalacia patellae or ligament reconstruction, whatever you do, in those cases, this Synvis injection or the visco supplementation, it should not be given during the surgery or after the surgery. You have to wait for at least 4 to 6 weeks after that surgery or the completion of surgery. Only then you should give visco supplementation. Only then it will be more effective rather than giving just after the surgery.
So the whole concept of visco supplementation will get diluted with the post-op inflammation and everything.
Yeah.
Everything will get washed out.
So I think they used to aspirate the joint and then inject. That was used to be the practice. And one of the reasons they used to do that, at least I know a few of our friends, was because getting it remunerated from the insurance companies would not be a challenge. So there was a issue with that patients would get it reimbursed only if they were admitted and it was procedure.
Yeah.
Now, another question, Dr. Saurabh. I mean, in this day and age, for let's say a short, stocky, middle-aged lady, early middle compartment OA, who you think is the ideal indication for injection, what would you prefer?
A lot of background noise that I can't make out.
We need to
and he got depressed.
Background voices.
Yeah. I think 2 people are logged on. I'm not the admin, but I can ask Poonam. Right. So the voice is also ideal indication. If you find a short, stocky lady who is early osteoarthritis, ideal indication for visco supplementation, which one would be your brand or which one would be a molecule you would go to, like your go-to visco supplementation?
So based on whatever, we have only used Synvis 1 and Duralum in our practice. So I'll rather give one injection Synvis 1 if I have to choose among the two, rather than multiple injections.
Right.
That will be my go-to brand. But having said so, I would not choose either rather.
So the difference in civil and our army setup is that whatever injection we give is we procure and give. It's free for the patient. So the cost benefit we don't have to consider. Rather, for you people in civil, you have to convince the patient that a 15,000 or 18,000 injection will give this much amount of relief for 6 months maybe, and then you have to take a decision with the patient.
Right.
So this and it's a major decision. Why? Because 2 injection each of say with the procedure cost, it will be something around 40,000 rupees. in 60,000 rupees, he gets a knee replacement implant. So in our setup, it remains that those patients who have like serving soldiers who are still active in their duties, whose joints have degraded not enough to require a joint replacement, but they require a mobile pain-free joint. So we do inject them once, see the effect, and if they are having a good relief, then we may try to inject maybe after a year or so.
Right. Excellent. Sir, I think, do you have any more questions, sir?
No, I don't think so.
Okay. I was just checking online. So online, there are good number of views, but there are no questions as such. I think they will keep on, the views will go on increasing as the days pass. And I think it's almost 9. So we can do it in case there are no questions. I just said.
Yeah, Dr. Sumit, if you have any other questions.
That was a very nice presentation and we had a good discussion. No more questions from my side.
Yeah, Dr. Rohit, your concluding remarks.
Yes, sir, it was a nice discussion with you, and it's always a good opportunity for us to interact with our civil surgeons. We also come across new practice and your practice, because the practice in our setup and your setup a bit there's a bit difference. So that's my experience when I was in AIMS. So it's opportunity for us also to interact with you and get your views regarding the current practice which you are following in your setup.
Right. Thank you. Dr. Saurabh, your concluding remarks, please.
Sir, thank you for this opportunity to present. It's good for us to have this open discussion with the stalwarts like yourself and other faculty here, and to learn. And as far as the Visco supplementation is concerned, the final verdict is still not out. We need to wait out till we get the final verdict. Still then, we pick and choose. That's my final verdict. Thank you.
Thank you. Thank you, Lieutenant Colonel Saurabh, for an excellent lecture with complete overview of the literature that you have done so much of literature survey. Really, we educated ourselves to a certain extent on Visco supplementation. And it was pleasure to have you, Lieutenant Colonel Rohit and Lieutenant Colonel Sumit, and to generate discussions and have what is the difference in the practice in in your setup and in civilian setup. I think it was an excellent webinar, and we look forward to having more and more interaction with you in what is happening in Army Medical Corps and all these things. So nice of you to devote time, all three of you, to be present here in this controversy and consensus in orthopedics. And I thank also Dr. ASHISH and Dr. DEEPAK GAUTAM joining today, and the OrthoTV people, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and of course Poonam is there to conduct this show. Thank you all. And before I conclude, I hand over the proceedings to Dr. PHADNIS for the concluding remarks.
Thank you very much, sir. And it was a very stimulating and a very comprehensive literature review, Dr. Saurabh. Thank you very much for that. I mean, I was just going through the slides that you had projected. I'm sure this is going to be, I mean, people can actually refer to the articles and the year. And the way you mentioned that the evidence is yo-yoing between recommendations and no recommendations, strong recommendations and weak recommendations was very good. I think this is going to be a good source of sort of reference point on OrthoTV, as well as, most of the resident doctors and junior doctors who make a decision. Thank you very much for that. And it was very interesting interacting with you, Dr. Sumit Bhandari, and Dr. Lieutenant Colonel Dr. Rohit Vikas. And it was I really enjoyed this. I'm sure a lot of people are going to find it very interesting. So I thank you all very much for joining us today. And on behalf of OrthoTV, so not behalf, but I would like to thank OrthoTV as the organizers for sort of, beaming this and cooperating with us. This is our 11th episode, and we will shortly be back for our next episode in the next week or couple of weeks with another interesting topic, with another interesting set of orthopedic colleagues who will put forth their views and the evidence for that. So I hope we have sort of satiated everyone's sort of need for arriving at a consensus in this controversial topic of Visco supplementation. Thank you very much, Dr. Mohanty, sir, for this opportunity. Thank you very much.
Thank you. Good night, all.
Thank you.
Poonam,